Good evening, everyone. Thank you all for being here this evening. I am Yolanda Johnson, your facilitator for tonight. We have a really great dialogue planned for you. But before we get started, I just want to remind everyone about the great organization that puts these critical conversations forums on. The Oncology Foundation of Maryland and the District of Columbia, which we like to call OFMDC, is an organization composed of community volunteers who want to make a difference in cancer education. The foundation was founded by the Maryland, D.C. Society of Clinical Oncology, a state society that's affiliated with the American Society of Clinical Oncology. The mission of OFMDC is to bring together in a non-competing forum patients, patient advocates, doctors, and the research industry to provide education and information on available cancer resources. I want to take 1 minute to thank you to all of the board members who are here tonight and those who may not have been able to be here. I know that they've worked tirelessly on this effort and to bring you really great education. So I just wanted to thank our board members. Tonight, we have a treat. We have a speaker who is going to share her expertise surrounding genetics testing and counseling. Aimee Macagney, did I get that right, Aimee, this time? Good.
Yes, you
did. Thank you. Aimee Macagney attended James Madison University, where she received her bachelor's degree in health sciences and a minor in biology. Aimee then pursued and completed a master's of science in genetic counseling at Virginia Commonwealth University School of Medicine at the MCV campus. Her training included providing genetic counseling in various settings, including prenatal, pediatric, adult, metabolic, cancer, and cardiology. Her passion lies in hereditary cancer predispositions. After graduation, Aimee moved to Maryland, where she is board certified in genetic counseling. Aimee started with Maryland Oncology Hematology in July 2022, where she continues to provide genetic counseling and testing to patients all across Maryland. One fun thing about Aimee that I learned was that she's into Pilates. And it's a great workout, she says, that doesn't put a lot of stress on the body. So some of us may have to try Pilates. And Aimee also loves to make crafts. So, she's a very fun-spirited, a very lighthearted individual. And I just want to say thank you to Aimee for being here tonight. Aimee, welcome.
Thanks, Yolanda, for having me. I'm very excited to be here tonight with you all and look forward to chatting about genetic testing and counseling.
Good stuff. So, Aimee, talk to us about what is genetic counseling, genetic testing, and how did you get involved in it? We heard your bio, but what made you become involved in this?
Yeah, so, as a student in college, I had a lot of opportunities to explore different avenues. Something I was always passionate about was not only sciences, but also the psychology side of the sciences. And so genetic counseling certainly combines both of those things. So with genetic counseling and testing, what it really is it involves talking about your family history, your medical history, and how that plays into genetics. We understand that there are hereditary predispositions to many different types of diseases, including cancer. And so with genetic counseling and testing, we're able to talk through the process of genetic testing, what that all involves. And then we're also able to do the testing itself. And with genetic testing, we can often look for these hereditary predispositions through a simple blood draw or saliva sample.
It's awesome. What makes you so excited? One of the things that I enjoyed from the first time speaking with you about is that you get excited about this work. What makes you so excited about it?
I think with genetics, as we all know, it's such an evolving field, right? It's an exciting, newer field within medicine. We're constantly learning new things about genetics, discovering new genes, understanding the genes that already exist and how they relate to cancer. And I think more importantly, this information I'm able to share with patients who may or may not know or understand what this is all about. And so that to me is really what gets me excited talking about genetics, and being able to help a lot of patients through understanding what their risk for cancer is and how we can manage them differently. I often come across patients who come into my office and say, I have no idea what genetics is, right? And so, that's where I get excited, is when I'm able to share that information with them so that they can make better decisions about their health.
Absolutely. Thank you for sharing that. We want to talk a little bit about the various types of genetic testing, but I want to encourage the folks who are on tonight to put your questions in chat, because as we talk, Aimee will also be addressing your questions at the end, and we'll be checking out the chat to see what types of questions you may have, or really thoughts or feedback that you may want to share. So feel free, if something comes up while we're discussing these issues, is to put your questions in chat and we'll get to them towards the end. Talk a little bit about the various types of genetic testing that's available. I don't know if everyone knows all of the types that's out there.
Yeah, absolutely. So when I think about genetic testing, I tend to categorize them. So there are tests that are available through your physician. So whether that be your treating oncologist, a genetic counselor, a primary care physician, gynecologist. And so those provider ordered tests are what we call germline genetic testing, or we also know there's another form of genetic testing, which is called tumor testing. And so I want to talk a little bit about the difference between those two. So when we think of the types of testing that gets ordered by your physician, so we think about a patient who has cancer, who's currently going through surgery or treatment. A lot of times, oncologists or surgeons will order what we call tumor testing. And so tumor testing is really looking to see if there are any what we call mutations or genetic changes that could help us understand what type of targeted treatment we can use. And so this particular type of testing is looking for what we call somatic mutations, or mutations that are specific to the tumor that aren't necessarily mutations that we're born with. And so, as I mentioned earlier, a lot of times having this knowledge can help oncologists understand how to best treat or target the specific type of cancer you have. With the tumor testing, there's also another form of testing called germline genetic testing. And what germline genetic testing is, it's usually looking through your blood or your saliva to figure out if you have any of these mutations or genetic changes that you can be born with. And so sometimes mutations are there from, what I tell patients, from day one, right? And they're going to be there until the day we pass away. And so it's something that gets passed down to us. So it's inherited usually from a parent. And so what my role is really providing that type of testing to patients, understand if they have an inherited risk for cancer. And I will say that this type of testing can be applicable for patients going through cancer, but also for patients who've never had cancer in their lifetime, but maybe have a strong family history of cancer. And so these types of patients, are able to get this type of testing, who may qualify based on their personal or family history of cancer. And so this is something that we're able to test for to figure out if they may have an increased risk for cancer that they're unaware of. And as a result of that, we can often change their management, which can include their screening or potentially having interventions like surgery to combat that risk. With genetic testing, of course, there's not only physician-ordered tests out there. Some of you may be familiar with some of the direct-to-consumer testing, as we call it, or DTC, which includes things like 23andMe, Ancestry.com, other online health tests. And so with these tests, I will say, these aren't often ordered by a physician. Many of you probably have ordered them yourselves online. It's as simple as adding to your cart, right? And so with this type of testing, sometimes it can provide health information. And so this type of testing sometimes is more convenient for patients to be able to order themselves. Although I will say that a lot of times this type of testing isn't necessarily as comprehensive as far as the diagnostic tests that your physician would order.
Wow, I can imagine. We've had some talks, and I had no idea that 23andMe and Ancestry.com could test my potential like risk for cancer. Um, so you mentioned tumor testing, you also mentioned bloodline testing, and of course the kind of mail order type testings. And I think that when people talk about or think about genetics testing, they think about this tough thing that may be tough on their body. It's kind of scary sounding, but it could be as simple as a blood test or even saliva check that could possibly save your life, in the future. Thank you for sharing that. Aimee, I think a lot of times people are not sure of where to get started. Like, how do I even start this process? How do I advocate for myself to have something like this if I think that there is a risk, or if I just want to check for the risk? How does one go about that?
Yeah. And, I think when it comes to advocating for genetic testing or taking those next steps, the best advocate is yourself. I always tell patients, you're your best advocate. And so I think it's always reasonable if you have concerns about whether it be your current cancer diagnosis, a past diagnosis, or a family history of cancer, to bring that up to your treating providers, whether it be a primary care or a gynecologist or your oncologist or surgeon. These are all people who are here to help you and get you and provide you with the best care. And so I think it's always worth starting a conversation with them. And then from there, they can refer you on to somebody like myself, a genetic counselor who's an expert in that field. There's also the option that you can come straight to us. Some insurances don't require referrals. And so at the end of the day, if you have questions or are interested in genetic testing, I always say, give us a call, schedule an appointment. It's always at least worth a conversation, even if at the end of the day, you decide genetic testing isn't for you. We at least started that conversation and can make sure that we're at least talking about these things and what we can do about cancer risk.
Yeah, thank you. You know, to speak to the direct consumer testing, what should people be careful about? As you said, they may not always be as valid, but what should people be careful about? Say they get a result in the mail, what should they do at that point?
Yeah. So, I think first and foremost, if you ever decide to do a direct to consumer test that includes any sort of health information, bring it to a provider. They are better at interpreting these types of results. Myself included, I can interpret these results, provide you with the counseling that oftentimes does not come with this type of testing. So, sometimes you get those results in the mail and you get a whole 10-page report and you're like, what does any of this mean? And so, I strongly advise patients to come talk to somebody, whether it be myself or another provider, to have those conversations about what this really means for your health. I think as far as what's on these tests, can be limited sometimes. So when it comes to hereditary cancer and looking at genes that are associated with hereditary cancer, oftentimes these health tests are not comprehensive. They don't look at all the genes that we understand about, or they may only look at particular variants or mutations within those genes, and we know about more than just those. So, even if you come back negative for the hereditary cancer genes that they looked at, it doesn't mean that there isn't a mutation that could be in a different gene that was not tested for. So being wary of that, and oftentimes these laboratories as well are not as regulated as some of the diagnostic laboratories that myself and other clinicians will order through. And so being aware that, some of the information may be misinterpreted or misleading. And so again, I think it's always important to come back to your physician to do confirmatory testing especially if they were to find something on your test.
It's great. Thank you. I read a write-up in an article that someone provided me who's close to this work. And one of the things that she said, just to quote, is that my breast cancer was detected very early because of the genetic testing. And so, as simple as that sound, that's huge, because I'm sure that that helped her start treatment early and things of that nature. So talk a little bit about the next step. So once that genetic testing happens and you get that positive thing, what happens then?
Yeah. So, once you've gone through genetic testing and, they find a positive result, meaning they found a mutation in one of your genes, essentially what that means is that they've identified you have a higher risk for certain cancer types. And so every gene out there has different cancer risks associated with it. So depending on that gene, the risks may vary. And so, based on those cancer risks, what we often talk about as the next steps are doing things like screening more often. So I can use the example, if we were to find you were at an elevated risk for colon cancer, one of the discussions we may have is starting colonoscopies earlier. So right now the recommended age is 45. Some genes, when you have a mutation in them, we recommend it as early as 25 years old. We also talk about doing screening more frequently. So instead of every 5 to 10 years, which is pretty much average for colonoscopy recommendations, we may do it as often as every 1 to 2 years. And so really identifying this mutation and the cancer risks associated can ultimately tell us we need to be doing things differently. And sometimes by screening more frequently or earlier, we're able to identify that cancer at an earlier stage. And as Yolanda pointed out, that is huge as far as treatment, because a lot of times cancer may be caught at later stages and it's just not as treatable. And so with this testing, we can identify that cancer risk, screen more frequently, and then of course, also potentially, if it does develop, catch it at an earlier stage.
Great. What are some cons of genetic testing? We heard a lot about the pros. Are there any cons or challenges that we should be aware of as it relates to genetic testing?
Yeah. So when we think about, genetic testing, in the sense of, a test that I would order or a physician would order, there are some implications for things like life insurance, long-term care insurance, disability insurance. So right now, the law that we have, it's called GINA. It stands for Genetic Information Non-Discrimination Act. And GINA essentially states that if you were to test positive, meaning you have a mutation related to hereditary cancer or otherwise, both your health insurance and your employment are protected under this act, meaning you can't be discriminated against for those. However, they do not include things like life insurance, long-term care, disability insurance. And so there can be implications for that. And the best way I can explain it is if you were to go to apply for a policy, say a life insurance policy, they often ask you those screening questions. One of them may be, have you had genetic testing? And if so, what were the results? And there are cases where insurance companies will deny you a policy. And as a result of that, this law doesn't protect you in that circumstance. And so that's something that can happen. So that's something I always mention to patients when they're going through the testing. And I say, if possible, if you have concerns about that, I say, let's make sure we have some policies in place, because that could potentially happen. Laws change over time, things evolve, but that's currently where we're at. And so, I think that certainly is something that some patients are concerned about. The other thing is sometimes these test results can be anxiety producing for some patients. Some people rather not know or understand their risk and are concerned what this would mean for them and their family members. And so, I normalize that is certainly a feeling that a lot of people have. And I'm happy to walk them through the steps of what we can do about that. And but it is part of it. And so it's normal to feel that emotion, to have that anxiety behind finding out this information.
Thank you. Thank you for sharing that, because I think that's really key for folks to know that they could be treated as if they have a pre-existing condition with some types of insurances, right? So
Yes.
that's really a really good tip. And thanks for bringing up the anxiety of it, because that leads into, the next part of our discussion is how do people navigate it and what types of counseling may be available to folks?
Absolutely. So, of course, myself as a genetic counselor can provide counseling. Oftentimes with somebody who goes through the process of genetic counseling and testing with me is we'll have a follow-up appointment where we go through all that information. And then I remain as an available resource to them after that process of talking about their results. And often will recommend following up with me on a yearly basis as a way to check in, how are things going, but also just kind of the changes that can happen with some of the recommendations or understandings about this particular gene mutation. As far as counseling goes, of course, there are some labs that will provide counseling as well. So if it's something that gets ordered by, say, your primary care physician or gynecologist who doesn't necessarily feel comfortable understanding or interpreting these results or how to counsel you on them, there are resources through those labs that they can also use to help with that anxiety, to help with those questions that you may have if a genetic counselor or somebody who can provide that counseling is not available.
Really good. Aimee, I often hear stories about kind of sometimes people being railroaded in their medical offices and, maybe not being heard or listened to. Some folks may have language barriers, some folks may have educational level concerns. And so, you speak in a very patient tone, where we can all understand, but not everyone is like that. When it comes to genetic testing and counseling, can I possibly bring someone else in with me if I don't understand all of the verbiage, or if I even need an interpreter?
Yeah, absolutely. So, I always encourage patients to bring whoever makes them feel comfortable to their visit, whether that be a family member, a friend, caregiver. I think it's always a great thing to have emotional support as well through this process, since oftentimes it can bring up different emotions. Cancer is something that's scary that, for people going through it, it can be tough. For people just thinking about the possibility, it can be difficult. And so I always encourage, patients to bring whoever that may be to help them. As far as interpretation or educational, barriers, I think that that's something that they can also bring somebody with them. We also have through Maryland Oncology, Hematology, phone and video services that provide interpretation. So if that's something that you're concerned about, I can be pretty reassuring that, we have somebody that can provide it in the language they feel most comfortable talking in and speaking in. So that's something that, I've had patients who come in, speaking many different languages and prefer to speak in that language. And even they may even speak some English, but because genetics is such a complicated topic, it's not uncommon for them to prefer to speak in the language that they knew first. So I absolutely encourage people to bring whoever makes them feel comfortable, but also know that we have people and services to make them feel comfortable as well.
Yeah. One last question before I open it to the audience to, ask some questions or even share stories. What does timing look like for something like this?
Yeah, so that's a great question. So with genetic testing in general, if you come to see me, for example, and we order genetic testing, from the day that you draw your blood to the day the results come back can be anywhere between 2 to 4 weeks. So it is a little bit of a longer process than most lab draws. The reason being is we use technology that is more advanced. It takes longer time to process that sample. So that usually is about usually how long it takes. And like I had mentioned earlier, I always have a follow-up after that time frame to go over the results, because I never would want to leave anyone, with results that they can't understand themselves. So yeah, the process usually takes about 2 to 4 weeks, I would say.
Thank you. Okay, let's see. We don't have any questions in chat, but feel free to take yourself off mute. We like to dialogue with you and create space for you to maybe share your stories or even ask a question.
Hi, Yolanda and Aimee. This is Pam. How are you?
Yeah.
So you're sharing stories, and as I mentioned to Yolanda and Aimee, I actually am a lucky, consider myself a very lucky person. I went through genetic testing, and because of genetic testing, I was diagnosed very early with breast cancer, which probably wouldn't if it's type that doesn't necessarily show up easily, or because my makeup doesn't show up easily on mammograms. So once I had that result, I immediately was sent in for an MRI, and I'm so grateful for that. I mean, that's not something you would normally get, and that's where they found it. One of the things that I think is you touched on being your own advocate, and I think that I can speak to that directly. When I mentioned to previous doctors my family history, I will say this: my mother had always said, my aunts and my cousin had breast cancer, be alert, but my mother didn't. And so when I would fill out the forms, they looked only at like direct relatives and my mother. So therefore it wasn't taken, I don't want to say it wasn't taken seriously, but there wasn't a connection there. And then finally I went through the testing, it was discovered, and I was talking to the genetic counselors. They said that that happens too often. And that it's really important to consider. And I was blessed. My mother and father have done a great job. My mother did a wonderful job of connecting all the family members so I could put it all together. But without that, it can often not be heard. The other thing I would highly recommend is to people, get all that information before you go to the doctors as much as you can. I mean, not everybody's as lucky as I am, but try and get your family history and go back that. So because I know what happens, you go to the doctor's office and they ask you to fill it out right there. Well, most people don't carry that in their back pocket or on their iPhone. So be prepared with the information so right away you can have that conversation with your doctor. Because once you're out of there, it's forgotten until the next conversation. So those would be my recommendations to people.
Absolutely, Pam. Thanks for sharing. And I think, you bring up some good points about these mutations. With these mutations, the risk for cancer is not 100%. So oftentimes there can be family members who may have this mutation, but don't necessarily have a history of cancer. And so, as you said, it can be missed. It's something that, oh, well, your mom never had cancer, so we don't need to worry about you. And that's a big assumption to make, because we know that these mutations don't confer a 100% risk for cancer. And so, any family history of cancer should certainly be looked at and scrutinized and question whether this is something that we need to think about, as far as hereditary cancer. And I think another great point you brought up too was knowing your family history. And of course, not everyone knows it. And I tell patients, this is something you know what you know what you don't know, right? And if you do know history, or you think you can get that information, it can absolutely be helpful to understand, if genetic testing is something we should be doing for you. But if you don't have those answers too, it is still available. I was just talking to Lisa prior to this, and we had talked about, some people just don't know their family history or anything about their biological relatives. And so, I have had patients who come to me and tell me that, and I say, okay, well, we don't know anything, but we can still order genetic testing. And through genetic testing, although insurance isn't likely to cover it because there's no family history, there is the option of self-pay, which is $250. So much more affordable than it was in the past, where genetic testing used to cost thousands of dollars. So, for a good majority of people, that's affordable. And for those that it's not, there are a lot of financial assistance programs. So, Needless to say, genetic testing is very much accessible, very much available. It's whether or not people are aware that it's there for them. And so, that's something that I really try and advocate for and make people aware. And that's why we're all here tonight to talk about it and hear about it.
We have some great questions in chat, Aimee. Denise says, in regards to life insurance discriminating against those with mutations, have you ever heard of military discrimination as well?
That's a good question. And there are, the military is a unique, unit in that they have a lot of their own laws. And that's something that I have had some patients concerned about. And so, to be frank, I don't know the exact laws behind military, but I do know that certain mutations can, cause somebody to not be eligible. I think I had a patient once that, had a relative that was trying to go through boot camp and wanted to know if they had this mutation or not, because it would make them either eligible or ineligible for that. So based on that. So definitely something for military individuals to think about, or at least have that conversation, with their individuals that they can speak with to talk about what that would mean for them in those scenarios.
Thank you. Aimee, what are the differences or like the effectiveness between the tumor testing, the biopsy and blood testing? What's the efficacy look like with that? And are there differences in mutations that show up in the different types of testing? That was from Pat.
Yeah, absolutely. So in general, between the three, I mean, they're all very effective tests in identifying what they're looking for, which is these mutations or genetic changes. The differences between the tumor, I believe the biopsy, when you say biopsy, is the liquid biopsy, as well as the bloodline or blood germline testing, is that the liquid biopsy and the tumor testing itself, so actually testing the cancer, is looking for those mutations that are what we call somatic mutations. So those can sometimes appear in the tumor, but not in your germline, so not in your blood, meaning it's not in all the cells of your body. It's not something you were born with. It's something that was acquired over time. A lot of times mutations can happen because different things that we're exposed to in our lifetime, sometimes sun being one of them, it can damage our DNA, right? That's one we know well. And so those are the mutations that they're often looking for in the cancer with the liquid biopsy and the tumor test. Sometimes mutations that can be identified on tumor testing can also be something that comes up on the blood test. And the reason is that the mutations that are in all of our cells are also going to be in the cancer, right? So something that we're born with is going to be in all cells, whether it be cancer, blood, elsewhere in the body. And so that's why sometimes mutations can overlap, but just because a mutation is identified on tumor testing doesn't mean that it's something that you were born with.
Thank you. Now, is that the same for like the efficacy of saliva versus blood testing for mutations? Denise had a question about that, and it sounds like it's kind of along the same lines.
Yeah, so with saliva and blood, in general, they can do something called DNA testing. So looking at the DNA specifically to see if there's any mutations. However, more recently, within the last several years, there has been something called RNA testing. So this is in addition to DNA testing that they can do for the blood test. And so unfortunately, right now, we're not at a place where we can do RNA testing on saliva. And the benefit to RNA testing is that in a very small percentage of cases, RNA testing can identify mutations that it cannot on saliva alone. But, sometimes RNA testing can also be helpful because there are times where we get back uncertain results from genetic testing. And sometimes RNA can help clarify what that uncertain result means. So in general, I would say it's a very small percentage of cases that RNA is helpful, But it is something that we're able to do on blood that we cannot on saliva. So in a way, blood testing can be a little bit more comprehensive than saliva at this point in time.
Thank you. Jackie had another question, or kind of a two-part question. Would it ever be inappropriate to have genetics testing? And is there an example of someone not needing it?
That's a great question. I think with genetic testing, for anybody who's curious, I don't think it ever hurts to have that information. I think as far as it being inappropriate, I think if it's something a patient doesn't want to know and a doctor decides to order it otherwise without having that conversation, I would say that would maybe be an appropriate time to have genetic testing. I think a big part of the genetic testing is that shared conversation about it, having informed consent about what the testing is really looking for, so that patients are aware of what type of information they can get back. Because at the end of the day, I would hate to see a patient who went through testing and didn't realize they can't get life insurance now, or that maybe they now know these risks that they didn't want to know. So I think as far as based on an indication, I wouldn't say there's necessarily an inappropriate time to do cancer genetic testing that I can think of off the top of my head. But I think it's important to have the conversation about it before it's ordered.
Yeah, that leads to a thought. Should we always be signing for informed consent, even though that sounds like it just should naturally happen, but we should always sign for that. So there should never be a time that a patient doesn't know that they're having genetics testing.
Yeah, I think certainly signing is a big thing. And then, confirming their understanding is another part of it too, right? Because we can get their consent with a signature, but the informed piece is really making sure they understand what we just discussed and what's happening. Because, at the end of the day, I think we all know there's been times where we've signed papers we didn't really read. And so we may not be fully aware of what we're signing off on. And so in my role, I think that's a huge part of it, is walking through the steps, explaining what the information is going to give us so that they're informed in their consent.
Thank you. Debbie asks, how many generations should one know about to share for best results?
Yeah, I think, it never hurts to know as much as possible. I think in general, we like to think about a 3-generation pedigree. So when we think about you and your siblings, your parents and their siblings, and then your grandparents. Ideally, we'd like to have information about those relatives, but understanding we may not always. And for some patients, they may know way more than that. I've had patients go back to their great-great-grandparents who knew they had cancer. So, I think that it may not change the outcome of results, but it may help us understand what the likelihood that there is a mutation in the family. The more that we know, the more that it can tell us, okay, there's a lot of breast cancer in this family. I think we need to think about testing, because the likelihood there's a mutation is much higher compared to a family that has no history of breast cancer.
Thank you. Pat's wheels are turning. If you get a result that shows mutations that can be used to guide treatment, what's next? And then there are new treatments and clinical trials all the time. I think you mentioned that. But once a test is done, is there a mechanism for picking up on a later development or clinical trial, while you're going through this treatment? Like, is there a mechanism through the process for that?
That's a good question. So, being that I don't play the role of an oncologist, I may not be as informational in this area. So, with the tumor testing itself, that tends to be ordered by, the oncologist. And usually with those type of testing, I often have to read the report because there can be indications for germline testing. But from, my perspective and what I understand is oftentimes, when they identify mutations, they will list the current drugs that are effective for those particular mutations that are identified. There are also a lot of resources online, from what I understand, on where to go to identify what those treatments are recommended. And then I think the next part of the question was related to, if, say, there was a mutation identified now and 5 years later, or let's say a year later, a new treatment is now available for that mutation that was not available. How do we track that? And I don't have a good answer to that question. I'm not familiar if there's a process for that. I don't know if it's individualized within the institution, if that's something we can go back on, or just something that the oncologist keeps up with as far as, what treatments are now available for that particular type of cancer. And feel free, if there's any oncologists on the line to chime in and answer better than I can, feel free to do so.
Thank you. I'm gonna give a few seconds of pause to see if anyone else has a question or feedback for anything that Aimee just mentioned.
I have a question. This is Susan Nolte, and I'm on the foundation, the board member of the foundation. I was just wondering if you have a success story that might help us inspire others to do this testing.
Yeah, that's a good question. I would say I have a lot of patients who I could consider, success stories. I think, with patients who I've identified mutations, almost always I have some type of story where they were able to change their screening, or they were able to take that next step to then do a prophylactic surgery. I've had patients where they identified BRCA mutation. You might be familiar with that term, either from Angelina Jolie, the news, otherwise. They were able to undergo prophylactic surgery, and it made them feel good at the end of the day because they were less concerned that they developed breast cancer like other relatives in their family did. I think I have a lot of patients who, didn't even know this was a possibility. And now that they know, they feel that they can be their own advocate in their health. So, I think even Pam gave a great success story of her own, where this CHEK2 mutation that she identified really, gave her that ability to be proactive and detect a cancer at a very early stage where it was treatable.
And in addition to that, it's also given me much more proactive, ongoing screening for this and treatment. I had many more treatment options that were available to me because of the mutations that probably wouldn't have been available to me had I not had it. So it gives me a greater peace of mind going forward.
Thank you so much.
Yeah, absolutely.
That. Thank you.
Pam did also have another question. As I understand it, new mutations are being discovered often. Should we undergo genetic testing more than once? And if so, how often do you recommend?
Yeah, so, I think I usually quote about every 3 years. I say, give me a call, see if there's new genes that we can test for. Sometimes we're discovering new genes that may or may not be relevant to test. If there's not a strong family history of colon cancer and there's a colon cancer gene, the likelihood we find a mutation is low. Is the testing available? Absolutely, but it may not be something we need to test for. But I think at the end of the day, every 3 years is a reasonable, I would say, time frame to say, hey, should I update my testing? And if so, then we can talk about doing that blood sample again. The one thing I like to emphasize with patients, though, is that although we can test for new genes, your genetic makeup is something that doesn't evolve over time. So, going back to look at the same genes is not likely going to change the answer, but certainly we can test new genes since that's something we weren't able to test for before.
Yeah. Doreen says, can you touch base on VUS and how patients may be aware if there is new data or if it becomes reclassified? I think that's related to variance significance. Yeah. So, if you can explain a little bit about what VUS is for folks who may not know what that is.
Absolutely. And so with a variant of uncertain significance, so what that means, so in genetics, there are 3 results that can come back from a test. It's either going to say it's positive, which is a mutation was identified, it's going to say negative, there were no mutations, or it may come back with what we call a variant of uncertain significance, or in the genetics world, we call it a VUS. So VUSs essentially mean they identified a variant or a genetic change in one of your genes that there's just a lack of information behind. So oftentimes, in order to know what an actual variant means, there has to be enough data to support it. And so when we get back these types of results, oftentimes we don't change management on it because we just don't understand about it. We don't understand enough about it at this point. But in time, what often will happen is the lab will gather more data, whether that be clinically from people who have this and what their personal and family history looks like, or just functional data that's done in the lab to better understand this. And so over time, they can reclassify these to either a benign finding, meaning not cause a higher risk for cancer, or they may come back and say it's what we call pathogenic or a positive result, meaning that they found enough data to support that it increases the risk for cancer. And so the question is that, over time, how can patients be aware of this new data? How can they track it? And so the best answer I can give is oftentimes the labs will notify the ordering physician about any reclassifications, whether it be benign or positive. I know some labs are a little bit different and will sometimes only do if it's a positive result now, but the best way I can say patients can track this is by creating their own login through the lab that the testing was ordered. And that's something that your provider can tell you what lab they ordered from so that you can create that account as well. And so that way, if the ordering provider, is not somebody you see any longer, or that, is just no longer at that institution, you can then track that yourself, and they can send you notifications when there's been a change in the classification of that uncertain finding.
Any questions, thoughts? Okay, Harold. Harold says, would there be any advantage to testing for someone in the past who has had cancer and is concerned with recurrence?
Yeah, so I think, as far as the testing goes, when it comes to the germline genetic testing, so the blood tests I've been referring to, I think that this test may not help us understand if there's a chance for recurrence of the cancer that you had in the past, but could tell us if there's a possibility for another type of cancer or another form of the same type of cancer that you had. And so, if this is something that you're interested in knowing, I think it's certainly a reasonable thing to discuss with your treating physicians or myself to see if testing makes sense for you. And certainly that depends on the type of cancer as well, since we know certain types of cancer, like lung cancer, are less likely to be hereditary compared to something like ovarian cancer, where there's a high rate of mutations amongst individuals with that type of cancer.
Thank you. And Dr. Barbosa added to the discussion earlier, she says, every genetic test is a success since a negative result can let patients breathe. More testing will lead to better reclassification of VUSs. Thank you for that. Mary says, how can we make appointments in Annapolis MOH for testing? And when I call, will the receptionist be able to schedule?
Absolutely. So I have Camille on the line who works over at Annapolis, if she wants to chime in.
Hey, Camille, you want to chime in here and let folks know how they can make appointments?
Well, yeah, you can hear me, right? I think I am muted. We see Amy's in our office on Thursdays, and she can do telehealths on Monday and Tuesday. What gets a little complicated, and people need to understand, is a lot of how we schedule is insurance driven, and that can create some, time and before we're able to get people in. But I think in most cases, having genetic testing, and Aimee, please correct me if I am not right, but I think in most cases, having genetic testing, it's not an urgent thing. So if you have to wait a few months for an appointment, it's not a problem. And I say that because if you're Medicare, it gets complicated because to see Aimee or Blue Cross Blue Shield and you're from outside our practice, we have to coordinate Aimee's schedule with our physician geneticist in our office, and that can be challenging to say the least. But if you have a regular commercial insurance, we can usually get you in pretty quickly. So I hope that answers some of the questions.
Thank you. I'm sure one question will be, does it speed up the process if I just pay out of pocket the $250?
No, it does not.
Yeah. No. And I think that the reason that is that, insurance, when you meet criteria, is often going to cover it. And the labs that we use are very good at what they do. And they are the ones that are running it through insurance and figuring that out. As far as, just paying the $250, it doesn't change the time or turnaround of the testing. So, at the end of the day, the testing is always going to take about 2 to 4 weeks, whether it's through insurance or through, self-pay.
Well, I guess it would make it, if you were to self-pay, if you were to self-pay, even for the appointment with Aimee, maybe, I guess is what the question really is. Would that, yes, I suppose it would get you in faster because we wouldn't be, I'm not really sure. So maybe I should answer that question.
Yeah, I think as far as, depending on, and for the testing itself, I would say it wouldn't change the time frame.
Thank you. Dr. Barbosa says, I would advocate anyone who has been treated for breast cancer should get genetics testing. Results may not only affect the patient, but possibly the family members as well. Thank you. Yeah, thank you both. And Tessie says, if you self-pay, does that not get put into a system to flag for life insurance?
So if you go through a physician, it will always be in your electronic medical record system. So if you were to see me, for example, and self-paid for the testing, your results would be scanned into your chart because it's part of the visit, it's part of our conversation. If you went through some of the direct consumer testing that is not done through a physician's office or a provider's office, then that would technically not be in your chart. But, again, I think we talked about the pros and cons today of what that would mean for you. But in general, for self-pay, the testing, again, is still something that will be part of your medical records.
Thank you. Jackie says we should note that with patients that are making surgical decisions, we see them immediately without regard for insurance. Thank you, Jackie.
Yeah, that's just a good point, a point to make with breast cancer patients, which we see often. Insurance and ability to pay is not a factor when they're deciding on their surgery.
Thank you. Mary has another thought related to the $250. Besides the $250 for testing, what is the charge for the consultation fee? Is there any consultation fee in addition to that?
So I think that's very dependent on who you're seeing, how their billing works. So yes, there's a separate charge always for the consult. So think of it like you're going to the doctor's office. There's always going to be some type of copay or charge for the visit. What that will look like for a genetic counseling visit varies on the institution and how that bills. Camille was talking about this a little bit earlier. Sometimes it's billed under a physician because of insurance coverage. Other times it's billed through the genetic counseling code. And that just depends on whether or not your insurance covers it for the visit. But yes, that is a separate charge compared to the actual testing itself.
But it's not significant. It's not.
Yeah. I would say most of the time it's usually like a copay. It's.
Thank you. Dr. Barbosa says, I was a co-author on the paper that changed the guidelines for ASBRS, so I submit that paper with orders if insurance are fighting payments. Thank you, and thank you for being an advocate for this. Wonderful. Speaking of that, Aimee, we have this great organization here that puts these critical conversations on. And this is some really good information that I feel like everybody needs. How do we raise awareness and we all become advocates for this, or at least, encourage people to have the conversations with, their providers and things like that? How do we get this information to the right folks to, get into your office or into offices like yours?
Yeah, I think, whether you're a physician, a provider, support staff, caregiver, patient yourself, I think the biggest ways that we know how to get things across are having those conversations, right? Having dialogue, whether it be with your patient, your family, your friends, staff members, otherwise, having those dialogues allows us to then spark that thought and say, hey, maybe I should be getting this done. I never thought about this before. I think that's a big way to get things across, word of mouth. Another way is social media, right? That's the world we live in nowadays, whether it be LinkedIn, Facebook, Instagram, TikTok, whatever that might look like for you. You can share that information and put that out there so that people are aware that it exists. And like I said earlier, the awareness is really where the issue lies. The access and the availability of it is there. It's just not the awareness of it is lacking of it. And so that's definitely something, those are ways and things that we can do to make people more aware of this testing option.
Thank you. Aimee, what happens to folks' information after they've done the testing?
Yeah, so, when it comes to the type of testing that is ordered through for your physician's office, what happens is they, of course, receive the sample, they run your test. Usually what happens from there, it depends on the lab. There's usually a period of time that they will hold the sample, and after that, they will discard it. The one thing I will say they will hold on to is your results, especially for those who have those uncertain results that they just don't know enough about at this point. And the reason they hold on to that information is so that they can provide you with better understanding and more information in the future. And so while we can't hold on to the sample and run more tests, we do have the data from that test to then be able to better understand your results in the future if need be. And then to kind of add to that, with direct to consumer testing, I'm sure many of you have heard on the news and articles, that information is very different. And you sometimes have to read the fine print with that because your data can be stored. There's been stories of it being sold elsewhere. And so being aware that that type of testing is very much different than the type of testing ordered by myself or other physicians in terms of the data and where that data is going.
Are there resources out there that you can point folks to that can give us more details or, more reading materials? And we can also send this out to participants and registrants afterwards. But if there's some resources that you wanted to bring up now, let folks know.
Yeah, I think there's a lot of great information out there. I think a lot of the labs that we use have a lot of great, videos or just patient information. Some of the labs that are out there, Myriad, Invitae, Ambry Genetics, GeneDx, that all offer cancer genetic testing. There's great information on like the NIH website, the CDC. I think there's a lot of great information out there in general. Medline Plus, gene reviews. There's a whole lot of different resources out there. And like Yolanda said, we can send you some more of those links so that you can check them out. But there's a lot of new information and a lot of available, understandable resources as well, because sometimes this topic can be quite complicated.
I'm Sure. What age groups are you seeing, Aimee? I think that's something that we wanted to touch on. What age groups do you see come in for
Yeah.
testing?
Absolutely. So I tend to see all adults. I don't see any pediatric patients within our facility. So, I've seen patients as young as 18 or 19 years old, all the way up to, close to 90. Anyone in their adult years is somebody I can see for testing. And the reason being is that a lot of times these mutations are adult onset cancer. So most of the time, these are things we're seeing into adulthood and not necessarily in childhood. So, I pretty much see very much a wide range of individuals. So don't ever feel you're too young or too old to come see me, because we know that mutations don't discriminate. They're, with whether, age, race, otherwise, it's something that affects everyone.
Sure. Thank you. We have a couple more minutes. I'm wondering if there are any questions or any final thoughts, feedback. Feel free to take yourself off mute.
I would just add something the doctor had highlighted as well, that it's not just about your test, it's the information. Then if you find something, you share with your family. And that's really, really important, because once you know something, then they get the testing done. And if they have the mutation, they now are eligible for the screening. So it's not, it trickles throughout your family, and it trickles down for generations, the more you know.
Absolutely. And, that's something in genetics we call cascade testing. So once we identify one individual with this mutation, we talk about who in the family next needs to get tested, because we know these mutations are inherited. Like we talked about earlier, it's something that gets passed down, often going back multiple generations that we're not even aware of. And so, when it comes to testing positive yourself, usually the next steps involve, getting children tested if they're over the age of 18, siblings, parents, aunts and uncles, cousins, to see if they also have this mutation as well. And oftentimes it can impact their screening and management based on that.
Yeah. Christina says, my grandmother passed away from pancreatic cancer 22 years ago. Are there genetic markers for pancreatic cancer?
Absolutely. And, with pancreatic cancer, we do know there are hereditary mutations associated with pancreatic cancer. It's about 10% of the time. So, enough where we can talk about testing, especially in this case, if your parents are still living and are able to get tested because their parent had pancreatic cancer. Ideally, we could test them first to see if they have a mutation that they could have then passed on to you.
Thank you. Any new updates? Go right ahead.
No, I was just going to say, this is Dr. Barbosa. I'm just so glad you guys are having this discussion. I feel like sometimes I'm the only one being booed out of a room as a surgeon talking about genetic testing. And I thank you for taking the time to bring up this very important topic, because we have tested less than 10% of genetic mutated carriers that are walking the planet today. So this is really important. And I think it's also important that as a surgeon, people realize that just because you're BRCA positive doesn't mean you need bilateral mastectomies right away. There's a lot of thought that needs to go on in terms of planning and looking at where a patient is. There's a wonderful program called Ask to Me, which will take your mutation and put you on a bell curve as to when you're at the higher risk. So I don't really advocate young women in their 18, 20s getting breast cancer if their family member got diagnosed later in life. So I think it's important to understand surgical treatment isn't the only option. High-risk screening is appropriate as well. And with new immunotherapies and treatments and diagnosis, I believe, hopefully, that within my lifetime, surgery will be the backup and not the front runner for cancer treatment.
Yeah, absolutely. Thank you,
Right.
Dr. Barbosa, for that. I think, as you said, there's a lot of options with these mutations, and surgery doesn't always have to be the first option, but certainly is available. And so, curating a plan for a patient is a large part of what we do as genetic providers, once we've identified that mutation.
Denise wants to know if there are any new updates regarding testing or new genes linked to hereditary cancers.
I feel like there constantly are new ones they're identifying. I think the large part or the bigger part that I think about with some of these new genes is, although we're identifying new genes, sometimes we don't have great guidelines on how to manage patients. So I think, while it's great we're identifying a lot of new genes, there's still a lot of information we need to learn about them. And although they're available for testing, we may not be able to come back to the patient and tell them what to do about it, which in itself can sometimes be a little bit scary. So, I think that it's great we're identifying more and knowing that information, and hopefully in time be able to give patients not only that information, but something that they can do about it and be proactive with. So as far as new discoveries, I think that's on a continuum. And will continue to be. The genome itself is huge, so I think there's always going to be room for more genes to be discovered, or at least more associations with these genes.
Thank you. Thanks, Aimee. I'm going to give it just another second to see if anyone has another question or thoughts, anything you may want to put in chat before we wrap up. Oh, Rachel says, what's the best way to stay up to date on changing screening guidelines for certain mutations?
Yeah, so one of the main resources I tend to use is, the National Comprehensive Cancer Network guidelines, NCCN. They're constantly updating those guidelines to reflect the new recommendations for these mutations. You can go to their website and there's, different hereditary guidelines in there that you can click on and look at the specific gene and what the recommendations are for that gene. There are other resources out there, like gene reviews, especially for the more rare hereditary syndromes that aren't always well described within the confinement of the hereditary guidelines and NCCN. Those are being updated as well to provide additional information for screening recommendations.
Hey, thank you all so much. Please be on the lookout for a follow-up email, probably within the next week or two, where you will get this recording and maybe a survey to give us some feedback so we can continue to build out critical conversations in educational programs like this. Please visit our website, ofndc.com. And we would love to get your feedback or your thoughts about any other information that you would like us to bring to you. Thank you for sharing so many great questions. And just again, thank you to our speaker tonight, Aimee. Thank you. I appreciate you and appreciate your passion towards this work.
Thank you so much, Yolanda, for having me. Thanks, everyone.
Absolutely. Thank you all. Have a great night.